of today's meeting, and may I call upon the co-chairs. Murad, you have a chair here, please. Philip, is Professor Morris in here? I know he's here, so yeah, please play Professor Philip. It's my pleasure, my name is Saeed Abdelhadi, to welcome you all to the second session. We're expecting a couple of the co-chairs, Professor Shash. I've seen him down, probably he is grabbing a sandwich or so. And Professor Laban, I haven't seen him so far. It's really a great pleasure to welcome Professor Nicole Constant. She's from Austria, and she's going to speak about another interesting topic in gynecology, especially the advanced epithelial carcinoma. The topic is surgical specifications and the management of advanced rare epithelial ovarian cancer, the mucinous, clear cell, and endometrioid. The floor is yours, Professor Nicole Constant.
Thank you very much, dear chairperson. Thanks for the nice introduction and particularly for the invite. I'm delighted to be here these days. Thank you very much. So this is about rare epithelial ovarian cancer and if this influences currently or if this should influence our surgical approach in advanced stage patients. These are my disclosures. We are all very much aware that the prognosis of these patients according to histological subtypes are differential, with particularly bad prognosis of the mucinous and of the clear cell advanced stage tumors, and this per se speaks for the fact that ovarian cancer, epithelial ovarian cancer, is for sure not one disease, but it is a very heterogeneous disease. So this talk targets the question if an individualized surgical approach per these histological subtypes should be chosen, and I will briefly target the impact of residual disease, particularly of small residual disease less than 1 centimeter at primary reductive surgery, and the same at interval cytoreductive surgery after neoadjuvant chemo, and at the end a couple of words on HIPEC in rare epithelial ovarian cancer. So this curve we are all very much aware of. This is from the German meta database, 7 pooled upfront ovarian cancer cohort, all high-grade serous tumors, and what we all know is that a complete macroscopic resection, of course, is the goal of our surgery and goes along with the best prognosis. But what I want to point out in this slide is that also a reduction of tumor load to small residual disease, less than 1 centimeter, gives a certain benefit in our patients compared to bigger than 1 centimeter. So even if you can reduce these high-grade serous ovarian cancer patients in tumor load less than 1 centimeter, they will have a limited benefit, but there is still a benefit. So this can be a surgical legitimate approach associated with less radicality in terms of morbidity, frail patients, if the patient has high-grade serous ovarian cancer. So what do we know about low-grade serous ovarian cancer? Here we have two conflicting data. To the left you see again the HO Germany meta database that clearly shows that there is a significant difference in prognosis of the patient if they have complete macroscopic resection less than 1 centimeter, the blue curve, or more than 1 centimeter, the red curve. In contrast, a study of about the same size from the US, the GOG study, here you can see between the blue and the orange, less than 1 centimeter or bigger 1 centimeter makes no difference. So here we have really conflicting data with respect if small residual disease is a legitimate approach. Of course, complete resection is the aimed one, but if it is legitimate, if this cannot be achieved, if it makes sense to reduce to minimal residual disease. mucinous. Here we have the wonderful paper of Philip Morris, who is here on the Lancet Oncology, Philip, yes, on the mucinous ovarian cancer. They should be discriminated into the expansile and the infiltrative type. Many of the data that we have do not differentiate these two types because it's a rare, it's a rare disease, so we have them pooled in the analysis, and you can see here that in mucinous really only complete macroscopic resection makes sense. There is no difference between less or bigger than 1 centimeter residual disease. So if you open this belly with the aim for a complete cytoreduction and you intraoperatively see you cannot reach complete macroscopic resection, then we close the belly and try not to reduce to less of 1 centimeter, because this will only come with morbidity for the patient, but she will not have survival benefit. Clear cell ovarian cancer, here the data are really sparse. You see what we have is only a retrospective pool cohort of 9 Japanese centers, slow case numbers, 91 cases. The US National Cancer Database, 240 patients with clear cell, so very limited data. But from the data we have, it seems that in this tumor entity, only complete macroscopic resection is a legitimate goal, and there is no difference of less than 1 centimeter or more than 1 centimeter residual disease. Endometrioid ovarian cancer, we really don't have nothing here. The data that we have mainly do not discriminate high grade, low grade, and we only have data retrospective on residual disease or no residual disease, but no discrimination between less than 1 centimeter or bigger than 1 centimeter. So to summarize, the first line is clear. Complete resection is the approach, is the goal in all these different histological subtypes. But in terms of residual disease, minimal residual disease less than 1 centimeter, it does make sense in high-grade serous. For endometrioid, we hypothesize they are similar, will behave similar than the high grade. So for the high grades, probably yes. The low grade serous, I showed you the conflicting data, but as is a less chemosensitive tumor, the primary approach to cytoreduce also to less than 1 centimeter seems a logical approach supported by the HEO Germany data. Probably the same for low grade, but for the clear cell and the mucinous, this really makes no sense. If you don't receive complete macroscopic resection, don't go further in your surgery. So what did we align on at the Ovarian Cancer Consensus Conference? 3 European societies held in June 22. The data are not published yet, but in preparation. Clearly, primary cytoreductive surgery is the preferred option and should be offered if complete resection seems achievable. For low-grade serous, we state that primary cytoreductive surgery is also the preferred option, and even if a residual disease of less than 1 centimeter can be achieved, this is the way to goal in these patients. So let's go to interval cytoreductive surgery and neoadjuvant treatment. From the approach, we have 4 randomized trials that compare primary cytoreductive surgery with neoadjuvant chemotherapy followed by interval cytoreduction, the EORTC, the CHORUS, the Japanese, and the Scorpio trial. And if we look at the data specifically for rare epithelial histological subtypes, you see again we have hardly any data. Look at the percentages, very, very low, so it's difficult to say anything about this from prospective randomized trials. What we have, again, very sparse data, retrospective character only, small patient number, 150, and what we can tell from this low-level evidence data that clear cell and mucinous do particularly bad with the neoadjuvant chemotherapy approach. If we look at the high-grade serous, the main population included in the randomized trials, you can see that two of them, the EORTC and the chorus, showed that interval cytoreduction was not inferior to primary cytoreduction. The Japanese trial showed that a neoadjuvant non-inferiority, this was all non-inferiority trials, was not confirmed. The Scorpio trial neoadjuvant was not superior. This is the only one that pre-selected all patients by laparoscopy with high tumor load. It had a second primary endpoint that was positive, the complications, the quality of life, but the neoadjuvant from effectivity was not superior. So what can we say from these data? Actually, they have been heavily criticized because of the low complete macroscopic resection rate. In our ESCO quality indicators for ovarian cancer, advanced ovarian cancer surgery, we emphasize that we want a rate of complete macroscopic resection in advanced stage disease of 65%. And if you look at the percentages here, they are very, very low. So this is certainly a valid critical point of these studies, and we are all eagerly awaiting the results of the TRUST trial. I'm afraid we will need to wait for this a while. This is a randomized prospective data, a randomized primary cytoreductive versus interval cytoreductive surgery, and here really the top class surgical skilled centers have been selected, audited, and only where surgical quality certainly will not play a role have been included in this trial, and this will give us a definitive conclusion on this interesting topic. So to summarize on the neoadjuvant chemotherapy approach in rare epithelial ovarian cancer, I've shown you that we don't have practically any valid data in the low-grade serous and endometrioid, certainly not in clear cell and mucinous. The only data that we really have is high-grade serous, high-grade endometrioid pool, and here this seems to be an alternative option. What do we say? In the consensus conference, we state that neoadjuvant chemotherapy with interval cytoreductive surgery is a valid alternative for which patients? For patients with a low likelihood of an initial complete resection and with chemosensitive, importantly chemosensitive tumors, so the high grades. In the GCIG consensus for clinical research, we say almost the same low likelihood of initial complete resection and chemosensitive tumors. For them, this is a valid alternative option. So what is about residual disease at the time of interval cytoreductive surgery? And from subgroup analysis of the EORTC and the Japanese trial, we see that there is no benefit if any residual disease is left after interval cytoreductive surgery. So they underline that we should go for complete resection and that only then the patient has a benefit, and if we do this surgery and leave any disease behind, the patient would not have a benefit. What other data do we have on this? There is a systematic review in 12 studies with conflicting data. Half of the studies showed that there is no difference between less than 1 centimeter, more than 1 centimeter residual disease, so stressing only complete macroscopic resection makes sense in these patients, but the other half of the study show exactly the same. So again, no clear answer to this question for the meaningfulness of leaving less than 1 centimeter residual disease at the time point of interval cytoreductive surgery in high-grade carcinoma cases, serous endometrioid. Certainly not an approach in the rare epithelial ovarian cancers. The last point I will briefly stress is the HIPEC, and Philippe will surely start smiling, because we had really the toughest discussion at the consensus conference in June in Valencia last year. This was a nightmare, the HIPEC. Very controversially discussed. I will present only one study which gives the highest evidence that we have today, and that had actually a positive primary endpoint, which was PFS, the primary endpoint. 240 patients, importantly only included FIGO stage 3, no FIGO stage 4 patients, and they were only included at interval cytoreductive surgery. They had either HIPEC at interval debulking surgery or not, followed by 3 cycles of carboplatin paclitaxel, and you can see the patients had significantly improved recurrence-free and overall survival benefit, so positive study. This talk is about rare disease, so if you look at the rare histological subtypes in this study, we have to clearly say again, we don't have any data on HIPEC in rare epithelial data. This is single cases included, particularly also to stress the mucinous, because the mucinous we still have in our minds from colorectal cancer, that this might be the entity where HIPEC is good. Also in colorectal carcinoma, the randomized actual phase 3 trial was negative. You see 3 cases included in this highest level evidence data that we have, so we cannot say anything about it. This Van Driel study from Netherlands was heavily criticized. A lot of publications on the weaknesses of the study. I will not go through all this. I just want to mention one thing, which is for me the most relevant argument. This study include a very specific subgroup of ovarian cancer patients only, which is only stage 3, no stage 4 disease, only patients with too extensive disease for primary cytoreductive surgery, but this was not defined. So this will vary from center to center. If the disease is too extensive to perform cytoreductive surgery, this strongly depends on the skills, or residual disease of more than 1 centimeter after primary cytoreductive surgery. I also not only work in Innsbruck in Austria, but also in Essen in Germany, one of the biggest ovarian cancer centers in Europe, and we have calculated the inclusion criteria for our patient population, and if we exclude all stage 4 patients, and many of them have some single extraperitoneal, extra-abdominal disease, an inguinal lymph node or metastasis clavicular, if you exclude them, you already exclude 1/3 of our advanced ovarian cancer patient population, not suitable for primary cytoreductive surgery without any criteria. Stage 3 with bigger than 1 centimeter excluded. This is the minority of patients in specialized centralized centers. So for us, this would mean 5% only of the advanced ovarian cancer patients that we see in Essen would actually be have been eligible for this study. So this is for me the most important point. This is a highly selected subgroup of patients, and I'd be very, very cautious to extrapolate these data to all ovarian cancer patients. So what can we say finally about HIPEC in rare epithelial ovarian cancer subtypes? Surely we don't have any data, we cannot say anything. The big discussion at the consensus conference was really the HIPEC at the time point of interval cytoreduction. Is this a good idea for all epithelial ovarian cancer patients with high grade? The answer there was no, but where the consortium was very separated in 2 parts is the Van Driel criteria, so really only the stage 3 patients high-grade serous stage 3 only. Here, half of the group said this is an option, half of the group said no. We could not find a consensus on this in the consensus conference, but the GCIG for clinical trial research states that any form of intraperitoneal therapy or HIBEC cannot be regarded as a reference treatment within clinical trials. And this is my last slide, the summary slide. So you can see for the different topics, for the different histological subtypes, it's a very colorful picture. So obviously tumor biology matters. Ovarian cancer epithelial is a heterogeneous disease, and we need to learn much more in the future how this molecular biology should influence our surgical approaches. And at the end, I have brought you a picture from my home, from the Tyrolean mountains in Austria to Cairo. Thank you very much.
Thank you so much, Professor Conson. We will keep the discussion till the end of the session,
Yes,
but
very
now
happy.
my co-chair, Professor Murat, is going to introduce the next speaker.
Thank you so much, dear Professor Said. Now the next